1. Which of the following best describes the purpose of risk adjustment coding? A. To ensure correct sequencing of surgical procedures. B. To adjust provider payment based on patient risk factors. C. To capture accurate anesthesia coding. D. To document outpatient hospital services. 2. In the HCC risk adjustment model, which of the following factors impacts the RAF score the most? A. Patient gender. B. Hierarchically coded chronic conditions. C. Provider specialty. D. Place of service. 3. Which type of encounter documentation is acceptable for risk adjustment coding submission? A. Problem list alone. B. Patient's past medical history section only. C. Face-to-face provider encounter note. D. Lab report without provider interpretation. 4. What is the minimum documentation requirement to support an HCC diagnosis? A. The diagnosis must appear on the claim only. B. Diagnosis documented in medical record with meet elements. C. Diagnosis reported verbally by patient. D. Diagnosis listed on patient demographic form. 5. The MEET criteria used in risk adjustment coding stands for A. Management, evaluation, analysis, treatment. B. Monitoring, evaluating, assessing, treating. C. Monitor, evaluate, assess, address, treat. D. Monitor, examine, apply, translate. 6. Which of the following would not be acceptable to support an HCC diagnosis code? A. Provider progress note with assessment and plan. B. Hospital discharge summary. C. Pathology report without provider's interpretation. D. Face-to-face encounter documentation. 7. Which organization is primarily responsible for maintaining the HCC risk adjustment model? A. American Hospital Association. B. Centers for Medicare and Medicaid Services. C. American Medical Association. D. National Committee for Quality Assurance. 8. Which coding classification system is used to determine HCC categories? A. C. P. T. B. I. C. D. 10. CM. C. H. C. P. C. S. D. D. R. G. 9. Which of the following best describes the concept of hierarchy in HCC coding? A. Higher severity codes override lower severity codes within the same condition group. B. The order of procedures performed during surgery. C. The sequencing of inpatient diagnosis coding. D. The order in which providers are paid. 10. When coding diabetes with complications, what is essential to capture for risk adjustment? A. Provider specialty. B. Specific type of complication. C. Patient's occupation. D. Patient's insurance type. 11. If a diagnosis is documented as probable or rule out in an outpatient setting, the coder should A. Code it as if it were confirmed. B. Code only symptoms or confirmed conditions. C. Code based on patient history. D. Do not code the condition at all. 12. Which documentation is required to validate a chronic condition for risk adjustment? A. Condition must be documented at least once per year with meet criteria. B. Condition documented once in a lifetime is sufficient. C. Condition must be reported only on a hospital claim. D. Only specialty providers can validate the condition. A RAF score is primarily used to A. Determine hospital reimbursement for D, R, G, payments. B. Adjust Medicare Advantage plan payments based on patient health status. C. Allocate state Medicaid funds. D. Assign CPT modifiers. 14. A patient has hypertension documented in a provider note, but no management plan or evaluation. Should the coder report the diagnosis for risk adjustment? A. Yes, as long as it is on the note. B. No, because meet criteria are not satisfied. C. Yes, if it was listed last year as well. D. No, unless the patient is hospitalized. 15. Which of the following conditions is most likely to risk adjust in the CMS HCC model? A. Acute upper respiratory infection. B. Type 2 diabetes mellitus with neuropathy. C. Sprained ankle. D. Titus media. 16. Which type of provider documentation cannot be used for risk adjustment coding? A. Physician office visit. B. Nurse practitioner face-to-face encounter. C. Medical assistant standalone documentation without provider oversight. D. Inpatient discharge summary. 17. What is the effect of coding unspecified diagnoses in risk adjustment? A. They often fail to map to HCCs and lower RAF scores. B. They increase reimbursement. C. They are always acceptable if documented by a provider. D. They count double in RAF scoring. 18. Which of the following best describes the suspecting process in risk adjustment coding? A. Using previous year's claims to suggest potential conditions for providers to validate. B. Assigning codes for conditions without documentation. C. Reviewing only lab reports for new diagnoses. D. Automatically applying HCC codes from problem lists. 19. In HCC coding, what does the term mapping refer to? A. Assigning CPT codes. B. Linking ICD-10-CM diagnosis codes to HCC categories. C. Sequencing DRG codes in inpatient care. D. Assigning modifiers to provider services. 20. Which type of conditions typically do not risk adjust? A. Chronic conditions such as COPD or CHF. B. Acute conditions with long-term impact. C. Common minor acute conditions like colds or sinusitis. D. Diabetes with chronic complications. 21. Which of the following is true about annual wellness visits in relation to HCC coding? A. They do not allow coding of chronic conditions. B. They provide an opportunity to validate chronic diagnoses annually. C. They must be excluded from RAF calculation. D. They are only for preventive screening codes. 22. If a provider documents CKD stage 4 in the note, what should the coder do? A. Report N18.4 to capture severity and risk adjustment. B. Report only unspecified kidney disease. C. Report the condition only if dialysis is mentioned. D. Do not code CKD without labs. 23. Which element of meat is demonstrated when the provider orders lab tests for a condition? A. Treat. B. Address. C. Monitor. D. 24. How often must chronic conditions be reported for risk adjustment purposes? A. Once every 5 years. B. Every calendar year. C. Once during initial diagnosis. D. Only when exacerbated. 25. Which provider types are eligible to document diagnoses for HCC coding? A. Physicians, nurse practitioners, and physician assistants. B. Only physicians. C. Only hospitalists. D. Medical coders. 26. Which of the following describes the difference between prospective and retrospective risk adjustment reviews? A. Prospective reviews occur before claims are submitted, retrospective after. B. Prospective reviews occur after payment, retrospective before. C. Prospective reviews use inpatient only, retrospective outpatient only. D. There is no difference. 27. Which of the following would typically be flagged during a risk adjustment audit? A. Diagnosis documented with meat support. B. Diagnosis taken only from a problem list with no provider interaction. C. Annual wellness visit documentation with chronic disease assessment. D. Provider note with clear treatment plan. 28. The ICD-10 CM guidelines for coding and reporting are updated. A. Annually on October 1st. B. Every 5 years. C. Quarterly. D. Only when CMS announces changes.